Hello, my name is Martha Madrano, and I'm a dietitian and a candidate for a master's in nutrition with the University of New England. I would like to present my study entitled What Barriers Exist Between Effective Lifestyle Intervention Program Participation and the U.S. Hispanic Population. The problem behind this research question is the large numbers of U.S. adults with type 2 diabetes, which is currently at 30.2 million. 84 million U.S. adults have prediabetes. So why should this problem be solved, or why is it important? Persons with diabetes are at higher risk for complications, and healthcare costs increase for everybody. Quality of life can decrease for persons with diabetes and work productivity as well. U.S. Hispanics are also at almost double the risk to progress to diabetes as non-Hispanic whites. Lifestyle prevention programs have been found to be effective, but increased participation is needed. So some background information. There's an increased prevalence of type 2 diabetes in U.S. Hispanics, and this has been related to lower socioeconomic status, at times low health literacy and numeracy, the language barrier, poor access or utilization or quality of healthcare, also targeted marketing of sugar-sweetened beverages to this population and other minority populations, cultural differences between patient and provider, and long work shifts, which can make it difficult to make it to medical appointments. Now, some of these are not unique to the U.S. Hispanic population. However, language barrier and cultural differences between patient and provider are unique to immigrant populations. The Diabetes Prevention Program that was published in 2002 was a 3-arm randomized control trial with at-risk subjects for diabetes. And the 3 arms were lifestyle intervention group, the metformin group, and the control group. So the results showed that lifestyle intervention group reduced their diabetes risk at the highest level at up to 58%, followed by the metformin group. Therefore, lifestyle intervention programs are designed similarly to the diabetes prevention program. So the methods to the literature search are shown above. Different databases were used through the UNE library site. The inclusion criteria included Hispanic and US and diabetes risk or prediabetes and lifestyle intervention and culturally adjusted. The exclusion criteria was non-Hispanic population, youth, children, adolescent, history of diabetes, or comorbidities. The literature review produced 8 quantitative studies, 2 qualitative, and many studies were used as background information. So to start, McClurry et al. Was a review of 12 studies in which body weight and A1C were the primary outcomes. Some of these studies were mixed methods, and 9 of the studies found significant improvements in primary outcomes. So the barriers collected through the mixed methods portion of these studies, the participants noted stress, lack of willpower, home food environment, time limits, fatigue, lack of motivation as barriers to participate in interventions such as the ones in the study. And some cultural barriers that were noted were spousal demands, limits on evening activity for women, family member food preferences. One of the qualitative studies that I looked at was from Brown et al. It was a small Focus group interviews on 36 Hispanic employees at a health fair. The aim of this study was to inform diabetes self-management education workplace interventions. The findings, these participants wanted healthy Hispanic meal prep. The barriers to participating in interventions such as this, per the participants, were long work shifts, family demands, and limited resources. A small mixed method study was attempted in rural population of Hispanic adults. The aim was to test efficacy and feasibility of a Vivir Mi Vida intervention. So it was mixed methods because there was a questionnaire that participants filled out on subjective symptoms such as sleep issues, stress, social roles. And the objective measures were cardiometabolic items such as blood pressure and intake. So the findings were statistically significant changes in the measure yourself medical outcome profiles. Systolic blood pressure improved, and subjective reduction in sodium and saturated fat intake. And the barriers to participating in interventions such as the one in the study were limited access, availability to healthcare, inadequate health professionals available, and low socioeconomic status. Another mixed method study by Soltero recruited Hispanic families that had at least one obese child. So there were measurements in both the adults and the children. So I did include this study because there were Hispanic adults in there that were at a high risk for diabetes. The aim was to find the efficacy of a diabetes prevention program in high-risk Hispanic families such as these. Results found statistically significant changes in waist circumference, percent body fat in both adults and children, and improvements in A1C in the adults only, and increased quality of life in both. Participants weren't asked specifically what the barriers were to participating in an intervention such as this, but the inferred barriers per the authors was lack of childcare, limited accessibility, language of the provider and education materials, and cultural differences. Marcus et al. Conducted a randomized controlled trial with 2 arms, and this study was based on the CDC recommendations for 150 minutes of physical activity per week to prevent diabetes. 205 inactive Hispanic females were recruited with BMI less than or equal to 45. Inactivity was defined as less than 60 minutes of physical activity per week. So both groups, intervention and control, received email alerts of new website upload, but the intervention group received access to tailored physical activity, goal setting, tracking, online help, and message boards for social support. So the aim of the study was to find the efficacy of tailored internet physical activity groups. The results showed statistically significant increase in moderate to vigorous physical activity minutes per week in the intervention group. The barriers that the study accounted for were limited transportation, lack of childcare, poor weather, and neighborhood safety. A mixture of cohorts and reviews had some major findings I wanted to point out. Hall et al. Conducted a study entitled Translation of the Diabetes Prevention Program to Ethnic Communities in the U.S. They reviewed 6 papers, and only one of them was on the Hispanic adult population. And they found that bilingual community health workers, a community-based intervention where Hispanic foods were considered, low literacy materials were used with lots of visuals, were effective. Phyllis Simikas et al. found that peer educators helped lower barriers, bridge the gap between provider and patient communication, helped clarify myths from cultural beliefs, and increase patient self-efficacy. So they highly recommend having a peer educator or a similarly cultural community health worker. Ritchie et al. Followed non-Hispanic whites and Hispanic participants in a national diabetes prevention program by the CDC, which is a year-long program. So classes are offered in English or in Spanish, and at the end of the year, at the end of the study, the Hispanic attendance was lower, and there was a larger number of non-Hispanic whites that lost a statistically significant amount of weight. So they are suggesting that culturally adjusted materials are likely needed. So the results show a collection of barriers. In the introduction, we noted that language, cultural, literacy level, and lower socioeconomic status are barriers that are well known. The studies, however, found perhaps some unique barriers to the U.S. Hispanic population, such as McClurry et al., where spousal demands, limits on women's evening activities, and family food preferences may have been unique to that population. Brown et al. Noted that long work shifts, family demands again, and limited resources, which is tied to lower socioeconomic status. Shepins et al. Found that limited access or availability to healthcare, again, maybe uninsured, maybe immigrant, maybe unable to get healthcare through their jobs, lower socioeconomic status, an inadequate amount of health professionals in the area. Soltero seemed to find what we found in the introduction, lack of childcare, limited access to healthcare, and interventions, language barrier, cultural barriers. Marcus et al. Found also that limited transportation to get to these interventions, lack of childcare, poor weather, neighborhood safety, which could be tied to low socioeconomic status as well. So despite lifestyle interventions available in Spanish, there's still a disproportionate number of U.S. Hispanics at risk for diabetes. Socioeconomic status, neighborhood safety, cultural beliefs and practices play a role in the target population's risk level. So studies found that culturally and literacy adjusted interventions provided by promotoras, which are community health workers in community, home, or internet, they found them to be effective. So to conclude, conditions stemming from lower socioeconomic status, health and literacy needs, and cultural practices were a common theme. Culturally adjusted community, home, or web-based interventions are effective in this high-risk group. Efforts should be focused on providing no to low-cost interventions. These interventions have been found to save money in total healthcare costs for the nation. So thank you for watching, and please post your questions below. Here are my references.